The Atlanta TMD Institute is proud that it's so the Atlanta TMD Institute was founded in 2018. We have three main missions. One, to educate dental and medical professionals in TMD, to develop knowledge of temporomandibular disorders, because there's a lot of confusion right now in the United States, and to successfully treat patients suffering with TMD. Most of our patients are referred by dentists and practicing ENTs, physical therapists, neurologists, ear specialists. So this is our mission. But this particular TMD training course is part of a series of courses offered to train TMD assistants so that they can do outstanding jobs in the TMD clinic assisting patients chairside. This is the second part of the course on POHD 6, and we're going to continue learning a little bit more about what to do at this very important 6-week appointment. Another really important thing that we do at the end of 6 weeks is remove the acrylic lingual ramps. But the patient must know their therapeutic bite. We have some criminal patients who never do their exercises. They do not practice it. You're supposed to look at them. You're supposed to, I have one person who's just like, here's exercise 1, get out of here. And he never sits and really makes sure they know with a mirror. Because how do I know? Because I say, make sure she knows exercise 1, and less than a few minutes later, the patient's up and leaving. That patient never got taught exercise 1, never did exercise 1 correctly, didn't realize there's a back page on exercise 1 with the water sipping, and just didn't do anything. But I hope that you are competent enough, caring enough, that throughout the first 6 weeks, you monitored the patient's training in exercise 1, because we want to remove those lingual ramps for various very important reasons at 6 weeks. And you need to check first to see if they've got that therapeutic bite correctly. Then you can remove them, only with my permission, of course. The purpose of the acrylic lingual ramps on the mandibular hard guard surface is to help the patient, the TMD patient, find and learn the therapeutic bite by themselves so that they know where it is all the time. I have a love-hate relationship with these acrylic ramps. I do. Do I like them? Yes and no. Why do I like them? Because they guide the patient's bite straight down into a locked position where they go into the therapeutic bite. They have to go into the therapeutic bite. It guides them in. They're locked. Do I hate it? Yes. I like patients to be able to move their joints everywhere, left, right, up, down. It is a healthy thing. Patients that have good mobilization of joints heal well. Remember, we're talking about cervical spine mobilization. Well, we also want jaw joint mobilization. And these guide ramps prevent left and right movement. But we use them for 6 weeks for teaching purposes. But we must remove them at 6 weeks so that the patient can start moving again. A lot of this has to do with the fact that there's no blood inside the jaw joint, right? How does the jaw joint get fed then with no blood? With this synovial fluid. Synovial fluid is like DW40. In a car, it's a feeding, it's a little, I think it's like straw-colored, thick liquid, and it lubricates and feeds the inside of the joint. It is swished around by movement of the jaw, so when the jaw moves, the jaw gets fed. This is interesting. So we do want to remove the ramps at 6 weeks. Once the patient knows the therapeutic bite, the lingual ramps can be removed since they have already done their job successfully. Let's get them out. Now they can move for the rest of their 20 weeks of therapy. You must be certain that the TMD patient knows the therapeutic bite by carefully observing the TMD patient biting up and down repetitively while you're watching on the appliance, always continually correctly into the correct therapeutic bite position. You know the patient knows, Now we can remove the ramps. And you can remove the ramps earlier than that if you think that they're doing extremely well. But you look at each visit on the bottom of the form you look at each visit. Is the patient biting in the therapeutic bite? You look at it. And then automatically, if they're not, you train, exercise one again and again and again. You do. So you should know if they're biting in the therapeutic bite correctly. So before we start cutting away the lingual ramp, you need to kind of know everything about this lingual ramp. Got it? So we're going to start with a triangle. The acrylic ramp is shaped like a triangle, okay? The triangle has a base on the bottom. It has two sides, right and left, and an apex, which is the tippy top, sharp tippy top. Apex at the top, base at the bottom, and then right to the right, left to the left, and we're just using this right. In this case, this is going to be the left side, the left ramp. Buccal side is facing the cheek. You see on the right side it says cheek, buccal side, and then on the left, the lingual side towards the tongue. Got it? So when you're looking at a ramp, tongue side is lingual side, the cheek side is buccal side of the ramp. The teeth slide down the buccal side into maximum intercuspation, into the therapeutic bite. Got it? The lingual side presses into the tongue. Patients are usually really happy when we remove this ramp because it's no longer going to press in the tongue, and the tongue is just so sensitive that when we remove it, they're like, whoa, this feels good. And so that's what you're going to be doing. We're going to spend a little time on this diagram because it's kind of important. This is called a cross section. It's like if you take a piece of butter, the long side, and you take a knife and cut it, you're going to get like a square inside the middle of the butter. So we are cutting up and down the patient at the first molar level, right? And this is the patient's left side. So if you imagine the patient facing you, we're just looking on the left side of the appliance in the acrylic pad area. Got it? Below, we have a crown of a mandibular first molar. Got it? And you can see the crown, and there's L for lingual cusp, B for buccal cusp. Notice I've got a dot right at the buccal cusp tip. Okay. Now, let's think about these appliances, right? The appliance covers the top of the tooth, which is the occlusal. If you look over to the right, it says occlusal acrylic covering the top of the mandibular first molar. Then there's some buccal acrylic going to the height of contour, right? It says buccal acrylic, that covers the front of the tooth towards the cheek. And lingual acrylic, which is covering the lingual side up to the height of contour on the lingual cusp of the mandibular molar, first molar. Then there's a ramp. See the acrylic ramp going up unnaturally. It goes up and it guides that upper tooth. The upper tooth will slide down the buccal side of the ramp into the little point where the lingual cusp touches. So let's look at the crown of the upper maxillary first molar. Lingual is the lingual cusp. B is the buccal cusp. And you'll know, let's focus in on that lingual cusp. The tip of the lingual cusp goes into a point, and I have a black point there, and it goes up. The line goes up. It says lingual cusp, contact, and I said blue because we use blue articulating paper. You do not touch that tip. You do not touch that lingual cusp contact. You do not touch that blue when you are adjusting the acrylic ramp. It's extremely important that you know and understand what is happening, how this is functioning, and where you can and cannot cut this lingual acrylic ramp down. Got it? So we're going to cut this lingual ramp down, and we cannot cut it below the level of the lingual cusp contact in blue. So just memorize that bottom of that little trough, what we call it fossa, the lingual cusp fits into acrylic on the lingual and the buccal like a hand and fist, locks in to that. We're going to cut the lingual ramp down in order to allow the patient to move more freely. Now, on the top, on the root, on the upper maxillary molar, we have the lingual cusp, buccal cusp in the crown, and then you got roots. You got buccal root and then a lingual root. I have the word root on the lingual. Then bone covers the root and gum covers the bone. And you see the red covering. That lingual ramp extends upward, doesn't touch the gums, does not touch the gums, but it is high. And I got it pretty high here, probably normal, higher than what is normal. When we cut the acrylic ramp off, we only cut it down at the level of the lingual cusp contact in blue, that blue thing at the bottom of the lingual cusp of the maxillary molar. Got it? That's the level horizontally we're cutting at. So I've blown up the appliance, and you'll see the lingual ramp higher than the red line. The red line is horizontal. It's parallel to the floor. The red line is very, very slightly above the lingual cusp tip contact point, that black circle. Got it? You will be cutting all of the acrylic above the line away from the acrylic ramp. There is a little hill in front or buckle that needs to be removed also, but we do that at another time. But there needs to still be a little trough, a little soup bowl, a little fossa right at the lingual cusp so that the lingual cusp will fit in slightly, very small. So the cut line is very slightly above the blue. So I will typically have the patient bite several times down hard, 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 make the blue marks showing where the lingual cusp tips are of the molars and bicuspids. And when I cut the ramp off, I make sure I do not touch those blue spots. And I try to keep a little bit of a soup bowl in the middle of those blue spots, both buccal and lingual. But the main thing is cutting this lingual acrylic ramp off. So if you see that, we're going to be cutting that lingual ramp off at 6 weeks. And we do it with an acrylic burr, the L04. So I'm trying really hard to make this less confusing so you know the concepts and how all this works. So the maxillary lingual cusps slide down the buccal side of the acrylic ramp and fall into the acrylic fossas where the blue dots are located. That is the contact point. Notice that the upper maxillary molar, the patient's not bitten all the way down. So they're going to bite. That lower tooth is going to come up because upper teeth don't move. But it slides down the buccal side. So let's take a look at the lingual ramp. This is confusing because the word lingual is in the ramp, so you think lingual. But the lingual ramp has two sides of the triangle, a lingual side of the triangle and a buccal side of the triangle. The buccal side of the triangle is where the lingual cusp of the maxillary molar slides down, is guided down from the tip of the cusp, lingual cusp, to the contact point in the mandibular acrylic fossa. See it sliding down. I have an arrow showing the sliding downward. The blue dots are the maxillary lingual cusp contacts onto the acrylic, occlusal acrylic. So you have the patient bite, bang, bang, bang. You get these little blue dots. They're the ones on the bottom where the arrow is pointing to. And then the upper, you'll see if you look in the mouth, the lingual cusp tips of the upper posterior molars, they have blue dots on them too. So you're not allowed to go near that acrylic fossa or any of the fossas where the cusp fit into the acrylic. So in other words, the arrow points down to the dot that you're not supposed to ever touch. No grinding on this, no cutting on it. So I really like the LO4 burr. It can be used for just about everything we do with our mandibular orthopedic repositioning appliances. So using the wider part of the LO4 acrylic burr, it's called a handpiece acrylic burr, horizontally cut the acrylic, the lingual acrylic downward to just above the contact points of the lingual cusp, indentations. Be super careful not to touch the bottoms of these functional fossas. That's the blue marks where patients bite in. After the LO4 burr has been changed, the LO4 burr must be changed after each use so as not to possibly spread infection. I'm noticing that lazy assistants don't do their job. Well, taking the LO4 out, putting in the cold sterile, and then putting a new LO4 burr in after each patient is mandatory. We buy these burrs in bulk. I have literally dozens and dozens of LO4s. We have way more than we need. So there's no issue here, and they should not be reused after each patient until they're sterilized. So you've angled the LO4 horizontally, and you cut the base of the triangle, and where it says cutaway, that's the base of the triangle, all right? And inside you see these little dots rolling inside the acrylic. We want to remove all the acrylic that is lingual, and it's kind of like another sideways triangle with a round base, but that's all going to be removed. But the first step is to cut downward horizontally, not to the depth of the functional fossas. See the dot? That we leave that fossa, we leave that little dimple, that little hole where the upper cusp fits in. We want the upper cusp to feel that little indentation so it knows where it is. But we cut straight down, back and forth, and then once we've got this, of course it's sharp, and we got to roll it in. And boy, have we removed a lot of acrylic. It's nice. And the patient's going to be a happy camper after you get done with that. But you do need to bring it to the lab and polish it with volcanic ash and water, and it's called pumice, fine pumice. So here we're rolling in the lingual acrylic. It rolls from the head of contour in all the way up to the fossa, the little tiny indentation. You can see the dot. That's where the lingual cusp goes in. And you'll notice it's rounded. We removed all that flat extra. Patient's tongue is going to be so happy. Think about how much extra room we're giving this patient. Before the acrylic went straight up high and down, that's a big chunk. If you can imagine what it used to look like, there's a big chunk of acrylic that's removed. And I'm going to, in the next section, remove the facial acrylic on the fossa. We actually do that when we deliver the appliance. And of course, it's very sharp on the buccal, so everything has to be removed and smoothed. But the main thing here is the next step is to remove the flat surface by cutting and rolling the lingual surface of the mora into the flat surface without touching the functional fossas. Functional fossa is where the lingual cusp goes in, little dot area. That's the function. You don't touch that. It is critical that you know that. I mean, you can have the patient bite down several times, but you can take a pencil and look to see where those fossas are and use the pencil to mark out each bottom. And that way you've got it very, very distinct. You can put it on the articulator and have it bite in so you can see what's going on. So you can use it, you can put the appliance back onto the articulator, mounted articulator. One of the things, we always look at the hand articulated models, but sometimes you can put the hand articulated models back on the Gelb articulator and use that to make your adjustments if you so desire. It all depends on your philosophy and what you'd like to do. The key is that this is something that goes in a person's mouth, so everything must be smooth. So let's take a look at the mandibular molar, and there's something called the height of contour, and this may be a little lower than height of contour. The height of contour is the part that pushes out the most, and the acrylic is supposed to go down to the height of contour. We want a really good fit. We want the acrylic to beautifully, tightly fit right over the tooth. That allows for retention. Retention allows for the patient to snap in, stay in, not move around. That's critical. You'll notice on the lingual part, we've cut off the flat area and then we rolled it in, and it goes all the way up to the little dimple, the little tiny fossa. There's a dot in the middle of the fossa, and the lingual cusp goes into that little dot. We've removed the acrylic on the front, the buccal. We went up a little higher. That's actually removed like when we delivered the appliance. I put it there because I was just drawing, and it's a way of illustrating to the fossa. And then it rolls down forward, and there's no sharp edges. And the acrylic has to be strong enough, thick enough so it won't break. So if you're thinking about it, one, you want it thin so it's not interfering with the patient's speech and tongue, but you also want it thick enough that it won't bust and break. But you'll notice that we cut away and roll the lingual smoothly all the way forward, and we'll polish that later after we do the cuts. Height of contour is abbreviated HOC in the lower left-hand side. More acrylic is the stuff on top of the tooth, inside the lines. So you don't want to touch, if you look on the right and left side of each one of these lingual arch bars, there's a hole. And the acrylic goes through there, and it's also, that area is a flat area that's rough. So the acrylic locks onto that hole. You don't want to go anywhere near the hole, above, below, or in front. Just leave that hole alone. Everywhere else, you're welcome to thin the acrylic. Typically, the acrylic goes past the hole. So in other words, on the second molar, there is no arch bar there, right? So the acrylic is sticking back. You can thin that. You can thin forward to the hole, and you can actually go to the metal on there. So next, thin the lingual posterior acrylic behind and in front of the locking hole located in the end of the lingual arch bar. So when you're doing the trimming, you can see through the ortho acrylic, stay away from the hole. So it is extremely important when you are finishing, it's a 6-week finish where you're taking off the ramps and you're thinning the appliance. You need to know that there's a lingual bar inside the appliance, and the lingual bar attaches at the end through locking holes and through grooves, locking grooves. So you can see through the acrylic, so you should be able to see these ends inside the acrylic. Never ever trim the orthodontic acrylic covering the locking hole at the end of the lingual arch bar. Don't go anywhere near it. Keep it thick right there. If you trim accidentally the orthodontic acrylic covering the locking hole, the posterior acrylic pad will break off on the side of the stainless steel arch bar. This only happened to me one time, get this, in 40 years, because we are really, really careful. I don't take any acrylic away from these holes and these locking grooves, because it holds. I know that most of the pressure, most of the retention of the pads, the orthodontic pads in the back with teeth bite into, the plastic pads are held together onto the bar through these holes and through these grooves. Removing the lingual posterior acrylic on both ends gives the tongue more room on both sides. So you're removing all of the acrylic in back of the locking grooves and the locking hole, in front of the locking grooves and the locking hole. You're thinning it, and what's happening is this is a lingual bar. Lingual means tongue, and now the tongue has more room. and there's more room above the appliance. And the patient just feels like, oh my God, I got a huge amount of room. I went 6 weeks with my tongue restricted. Now my tongue can go anywhere at once. I feel so good, and patients will really thank you. And then, of course, since you've trimmed it, it's a little rough. You got to go to the lab and put a high polish on it. So you might say, like, hey, Dr. P, why are you taking all this stuff off? Why didn't you just take it off right from the beginning? Well, when the person first came in, they're clenching and grinding and hard, and their muscles were tight. Everything was hurt. They're beating the hell out of their appliance, right? That's number one. Two, they didn't really know the therapeutic bite, and it was hard for them to learn it. Having the ramps slides their bite into place, and we're hoping that in a 6-week period, they will learn the therapeutic bite automatically. What am I trying to say? When you walk, you don't think, right? You just walk correctly. Well, we're hoping that at 6 weeks, the brain will bite into that bite normally, like regular walking, without even trying to position anything. It will just go to that bite. Got it? So at the end of the 6 weeks, they know the bite, we pray. We're checking that every time they come in. You need to be a Nazi when it comes to the therapeutic bite, because if it goes half a year and they don't know what they're doing, we're in trouble because they're not going to get better. But a great deal of orthodontic acrylic can be removed from the mora at 6 weeks because the patients learn the therapeutic bite, so the ramps are not needed, and the patient's muscles are relaxed, so they're not going to beat the hell out of this thing. This is why you must constantly check at every visit to see if the patient has learned the therapeutic bite, because it is required that they learn the therapeutic bite when you take the ramps off. Got it? And there are other reasons why we really should take the ramps off at 6 weeks. Inside a knee, inside a jaw joint, there's no blood, right? It's called synovial fluid. So it's like a straw-colored, thick, viscous material that feeds the inside of the joint. And in order for it to get distributed, because there's no pulse or blood vessels, you need to move the jaw around. And the ramps prevent the patient from moving left and right. So I want to get rid of those ramps as soon as the patient learns the therapeutic bite at a maximum number of weeks of 6 weeks. Very important. So this is critical. This is why the 6-week appointment is so critical. And if you say, oh yeah, you can come in at 10 weeks, I'm sorry, wrong. And 4 weeks, maybe sometimes I might pull it off. But if I'm at 4 weeks, I'm going to make it at 2. So I'll have it at 6. That's just my domain and how I think about things. It's my protocol, so I won't forget things. So here's a Gelb appliance, Dr. Harold Gelb, my main mentor. You'll notice that the front 6 teeth, the anterior teeth, lower anterior teeth, do not have any acrylic over them. We very often do that to strengthen it, but we remove it later. He doesn't do that. He just puts it in like this. And he has very little dimples on what people bite into. I have deeper indentations and ramps because I'm training them to get into the therapeutic bite. And he relines these things, like he charges every 6 weeks significant amount of money to reline it. I don't have to usually reline mine, so I'm saving the patient money too. So again, let's examine this. I've got it labeled A, B, C, D. All right, the little areas of the actual appliance. So the areas to be removed within at 6 weeks after the patient has learned the therapeutic bite, they're in automatically. So you remove both of the lingual ramps, right, in the posterior area. We talked about that. 2, remove the acrylic off of the lingual bar. So where it says A, the metal is the lingual bar. So in the anterior area where it says A, all that's removed, and we basically go from my device to a Gelb type device. Like it ends up like this. There's no acrylic on the cuspids. It's all removed in the back, and the patient's like, whoa, this feels good. So remove the acrylic off of the lingual bar, the lingual gums, and the lingual of the anterior teeth in the anterior region between the mandibular cuspids, right? So you can see the right and left cuspids do not have any acrylic on back of them. 3, thin the acrylic in the area between the anterior region and the locking hole and locking groove. So this is B. Area B is in front of the locking hole. You can look and see on the right, there's a hole in the arch wire, in the lingual bar. That's a locking hole. We don't want to ever touch the locking hole. We don't want the acrylic to bust off. But you can thin in area B. Of course, you can't touch the bite on the top, but you can thin this out, right? You can actually take all the acrylic off of the metal, at that point, not near C, but thin this out, going straight up. You'll learn this with time, right? So C, 4, leave the area around the locking hole and locking grooves alone. That's C. See these little holes that go through the bar. You touch that and the plastic will pop off of the bar. 5, thin the area behind the posterior of the locking hole and locking grooves. That's area D. So you can actually, again, we're all cutting on the inside, not the outside, not in the buccal area on the front of the tooth, not on the top of the tooth. We don't touch any of that. We're giving the tongue, where it says the tongue is in here, we're giving the tongue more area to function in, and the patient breathes a sigh of relief. There's so much more room now, and we've trained that tongue to stay out of that area too, right? And then you polish it. You do a high polish after you do that. And this is at 6 weeks. So again, it's worth reviewing. You can see how A is, there's no acrylic on A above the bar, below the bar. There is acrylic going backward into B. B is thin. You don't have to remove all of the acrylic off of the bar, but you want to thin that, right? A lot of times I'll have the patient bite, so they'll make blue marks in the occlusion, and I won't touch that at all. Everything else I can remove on the lingual. C, you leave alone, and D gets thin so that the back of the tongue has room. So when the TMD patient first came to the office, they had a lot of muscle problems, real tight muscles trying to fix joints that weren't right and the head position. Everything was tight and painful. When the TMD patient first came, all of the masticatory chewing muscles were tightening and shortening, which caused tooth grinding and tooth damage. It was bad on almost all of our cases. So in most cases, these muscles are now at 6 weeks much more relaxed, and the extra orthodontic acrylic, which is the clear acrylic, the extra orthodontic acrylic is no longer needed to resist the original high pressures. They're no longer grinding on that high since the muscles have now relaxed. If you have verified that the patient has learned the therapeutic bite by the patient going exactly to this bite without hesitation, without shifting, without thinking, you can then remove the lingual guide planes. And the guide planes, as I said, I call them railroad tracks. They're technically lingual guide ramps. So different people have different names for these things. And you'll hear different things, but I like RR or railroad tracks. This is it just tells you what they are. I'm spending an awful lot of time on this, what I call slenderizing, slenderizing the appliance at 6 weeks. Because most of the appliance was a teaching instrument, and also to teach them the therapeutic bite, and also to resist their grinding. So we needed the strength, we needed the teaching things going on. And so you, the assistant, needs to be able to do this whole thing without me in the room. I don't have to be there. You can write the prescription for PT. I don't need to be there. You can check them for the therapeutic bite. I don't need to be there. And get this, you should absolutely be able to show them, like go to Janet Travell's Red Book and see how their neck muscles are causing pain for them, and explain how the neck is related to the to TMD. So when you give them the referral, you'll show full confidence that that referral is needed, and you'll also educate them rather than me having to do it. And there's no reason for me to do basic, simple education. It should be you. So again, we're spending a lot of time on this slenderization process. Study the hand-articulated masticast to see if the upper and lower anterior teeth touch in the therapeutic bite. So remember, before I walk in the room, before the patient's seated, you have the maxillary and mandibular masticast in the wax bite articulated. That's what it calls hand articulated. And if the front teeth touch, hallelujah, then you know that you can, since they touch, they're not going to erupt. This is a hard concept, but I don't want to get into it right now. All I want to say is that if the front teeth touch, they're not going anywhere. So you can take all the acrylic off of the A area. So study the hand articulated masticast to see if the upper and lower anterior teeth touch in the therapeutic bite. If they do, the lingual acrylic behind the incisor teeth and the gums can be removed all the way down to the metal lingual arch bar. Just take it out, cut it out, right? Never remove the lingual acrylic behind the mandibular cuspids. Never remove the lingual acrylic behind the mandibular cuspids from the gums above the bar and from the metal lingual bar, which is, the cuspid area. Interesting. In my appliance, we try to keep something called cuspid guidance, and I'll go over that. So it's possible that this is not absolutely correct. But we'll get into this and I'll go over it with it. But if there's cuspid guidance, there's actually you can see a plastic cuspid coming off of the top. Then we want to try to keep that. But you're never going to go wrong removing the acrylic off a bag. You might have to look to see if there's cuspid guidance, and you might please come to me and say, hey doc, is there cuspid guidance? Do you want to keep it? Can I remove it? That's all. So the acrylic over the lingual bar in front of B, it's in front of the cover, it's in front of the locking hole, locking grooves can be thin. So the acrylic over the lingual bar in front, the B area, of the locking hole, locking grooves can be thin. You're thinning it outwardly towards the teeth, right? So the tongue has more room. You can even remove all of the acrylic from the lingual bar in this area if the patient is doing really well, because the acrylic touching the bar helps support it. But if the patient's doing really well, muscles are relaxed, they're in the therapeutic bite, they're telling you they're doing great, you can actually trim the acrylic completely off of the bar in B, but definitely stay away from the locking area. And this should be like completely in your head that you never remove acrylic in front of the locking holes and the locking grooves. So look at C on the right and the left, you'll see the hole in the bar. You don't ever touch that acrylic. Leave it alone. If you touch that, it's going to bust off. And that's crazy. And don't do that. So you never remove any acrylic below or on top of or in front of the locking hole, locking groove area. The orthodontic acrylic pads will fall off if you cut acrylic off of the locking area. So the area D, notice that it's in back of the locking hole. That area where D is can be thinned inward, under, even shortened slightly if you want to, but it has to be highly polished. But the back of the tongue goes in there. We're going to slim down and thin most of these areas. So you can thin the acrylic on the bottom of the mandibular orthopedic repositioning appliance, the mora, this is called a mora, behind D, the locking hole and grooves. I put a picture in here of the cuspid. The vampire tooth is what I call it when I'm talking to patients. I use slang terms. Slenderizing means cutting all the acrylic, unnecessary acrylic off of the appliance at 6 weeks. I say we're taking the railroad tracks off, the lingual ramps, so we use slang. These are the vampire teeth, slang. We're talking to patients. The cuspid is really, really important. It rips, and it's the only tooth in the mouth that uses the head movements. So when you rip, you're taking your head, holding the cuspid with your hand, and ripping your head to the side. This cuspid has special neurological nerve connections with the neck. So very important tooth. So I like to have cuspid guidance. It's where one cuspid rides along another cuspid. Just remember, what is cuspid guidance? It's when the lower cuspid touches the inside of the upper cuspid and slides along it. That's all. Write that down, memorize it, and then as you learn more and more about what they call occlusion, the way we bite, you'll learn what this is all about. So I've made like a quick diagram of this particular, this is a sideways. We're looking sideways at the appliance. Got it? Uh, the lingual arch bar, you can see the hole in the middle. And as you go forward, it's in acrylic. The bar's in acrylic. And then all of a sudden the bar comes out. It's metal. So I got it in dark. As you go to the left, that's the back towards the throat. Right is front. Got it? So posterior means behind, occlusion means bite. So posterior occlusion occurs in the back of the appliance to the left. The back teeth, the back teeth are the bicuspids, first and second, the molars, first, second, and third. First molar, second molar, and wisdom tooth. This is all acrylic. You can see that the appliance is made out of acrylic and it fits over the teeth. So you can see the teeth on the bottom. The acrylic is fitting onto the teeth and the bars inside there. The cuspid area, which is the vampire tooth area, is in the front. And you can see there's a big mound, a hill right there. And that is a make-believe lower cuspid. Just remember that the cuspid area, the cuspid hill, is a make-believe cuspid, so that when the patient bites, that the upper cuspids feel, F-E-E-L, touch your finger, you're feeling. So a lot of patients, when they bite down, their cuspids don't touch, or they don't touch when they move left and right. So we're going to try to build in something called cuspid rise. So let's go over that. The orthodontic acrylic creating the cuspid rise, sliding the lower plastic will touch the upper real cuspid when they move left and right and slide. The orthodontic acrylic creating the cuspid rise is the last acrylic on the mora that we trim down. We don't necessarily trim that down at 6 weeks. Got it? And this is why you got to look at the appliance and say, where is the cuspid rise area? I'm not supposed to touch that. And that's not done at 6 weeks. Removing the mandibular cuspid acrylic is often done at 13 weeks of successful mora wear, not at this POSHG 6 appointment. And this is a really important concept, and you need to learn it. And that's one of the reasons why I think it's so critical that you learn how to make these things. You actually sit down and apply the acrylic, bend the bars, learn all this stuff, because as you build the appliance, you start understanding what each part of the construction is for, right? And why it helps the patient, how it helps the patient. And so we get into this area, which I didn't address very well, I have to admit. I said take off the acrylic from cuspid to cuspid on the inside at 6 weeks. I did say that, but I did not want you to remove the cuspid area above. Got it? And so you got to really study where is the cuspid area. You can put the horseshoe articulating paper in the patient's mouth and have them move left and right. You'll see the sliding of the cuspid, the upper cuspid on the acrylic. You don't want to touch any of that area. Got it? A lot of it is things that you have to learn not to touch. You should know what each area of the appliance is named and what it's used for. Posterior occlusion, cuspid rise area, the metal lingual arch and the anterior teeth. Learn all this stuff. So on this diagram, we are looking down on the appliance, and we've got the two pads, the posterior tooth areas, which are the right lingual pad, posterior pad, and the left lingual pad, posterior pad, whatever you want to call it. There's 2 areas on each pad, 4 areas total. The cuspid area, or the cuspid hill, is forward, and the posterior tooth area is posterior or back. Got it? Leave that cuspid area alone. Leave that cuspid hill alone. Notice you've taken the acrylic off of the lingual of the anterior, but you're going to be very careful. I really feel like it's important that you learn how to make these things, how to make these appliances, because as you learn how to make them, you'll know what areas are important and how they fit together in the appliance, and basically by making enough of them, you start understanding what they do, because you have to, I can't forget, I didn't put the cuspid rise area in. I can't forget, I put buccal bite in. Buccal bite is when the upper teeth, on the upper teeth, only the lingual cusps bite. The buccal cusps are out. They don't touch anything. You cut all the acrylic out of the way for these upper buccal cusps. Very important. So these are muslin buff wheels, and they're used to polish and smooth the orthodontic acrylic. We use clear orthodontic acrylic made by a company called Lang on moras, mandibular orthopedic reposition appliances that you've just trimmed. So it's 6 weeks. You've really trimmed up this whole appliance to make it so much more comfortable. Now you want to go into the lab and smooth it down, right? You're only allowed to use each muslin buff wheel once. Once it's used, we don't use it on 2 different patients. We use it in the same patient. We clean it off with water and then put it into the washer and dryer, right? Please don't use them more than once. I heard somebody did that and I'm really upset. The same with the pumice. Pumice is, once you've used the pumice on a patient, you throw it out in the basket and then clean it and clean the what is it? The mixing bowl. Yeah, clean the mixing bowl. So use 1 wheel per patient. Never use the same wheel twice for 2 patients. We don't want to contaminate one patient with the other, especially now with COVID-19. We need to be very careful. Please, please be very hygienic. So you're going to wet the muslin wheel with water from the tap and then place it on the left end of the dental lathe. And you can see a dental lathe here. This is a baler lathe, and it turns the muslin, right? There's little attachments at the end that the muslin sticks onto. And we never use any gloves when you are working with the dental lathe, because the gloves can get caught, and very powerful lathe, they'll pull you in, break your wrists. So do not use latex or nitrile gloves when using the dental lathe, since gloves can get caught in the lathe and suddenly pull your wrist into the lathe. Very important that you don't use gloves at the lathe. And when you turn the lathe on, you've already wet that muslin buff, right? So the water goes everywhere. So always be aware that there's going to be water flying everywhere. And I put the muslin buff on at high, which is to the left. And then when I'm ready to polish, I switch it to the right, which is normal or slow. So we use fine dental pumice. So fine dental pumice is volcanic rock that's been ground up into a very small powder. Sometimes these rocks, people will use them to trim their feet, right? This is little pumice stones that you can buy to basically file away at your feet to take away the skin. So we usually buy these things in 25 pounds, right? Because we use it so much. We should never run out of it. It's not an expensive item. This is a concern of mine. If you're going to be working in the lab, you should always be concerned about how much of an item is left. We don't want to run out of dental pumice. We use it all the time. It's not that expensive. So, however, it's a big box. Like takes a while for it to be shipped to us. So we don't want to run out of it, right? So look in there. Is there plenty of pumice? And is there a backup box of pumice in case we run out of this one? These dental mixing bowls should be ultimately clean, right? And that's your responsibility. If you work in the lab, you should be proud and clean, 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 clean. Everything is clean, and the bowl should be spotless. And the best time to clean the bowl is after you've used it. And unfortunately, I go in the lab and I see that people just left them. They didn't listen to me, even though it's extremely easy to clean a bowl after you use it. They still don't do it, and I don't know why. I just don't know why, but I know it's one of the most frustrating things for me to go in the lab and see dirty bowls because people don't care enough to clean up after themselves. So place a small amount of fine dental pumice, and there's usually a scoop in the pumice, scoop it out into a clean dental mixing bowl with a small disposable drinking cup that we use a scoop or a drinking cup in the pumice, and wet the pumice with clean tap water until it becomes a thick consistency. And you can mix it around with your fingers so that you've got the pumice like mixed up into a gritty little thing, gritty little paste. So it's very important to be extremely careful when you are polishing the appliance, the mora, after slenderizing it. When you're trimming the mora, you want to be smooth so that when you do the polishing later in the lab, it'll be easier. But you can make a lot of mistakes. You can really screw up the appliance and screw up the patient. Seriously, you really need to know how to do it right, and you shouldn't do it unless you know. We recently had a new young lady go polish appliance, and she unfortunately got the retainer balls pushed outward. So I had already adjusted it. It fit fine. She went out to the lab, and when she was polishing it, she was pushing into the retainer balls, and she didn't understand you can't touch the metal ball clasps, right? You cannot touch them because they lock into teeth, and if you take that polishing wheel and push on them, it will spread them out of place. And when they won't, you go back and put it back down in the mouth, there's nothing locking in anymore. And the patient says, this is really loose, right? So you're only allowed to hold and polish the acrylic on one posterior acrylic pad at one time at once. So hold towards the back and then hold towards where the cuspid area is on one side, polish that side. Don't touch the other side at all. Hold both sides of one pad when polishing that acrylic pad. So you're holding the front, anterior, and posterior area of that pad on one side. This avoids bending the stainless steel lingual arch. And if you bend the arch, of course, think about it. It fit in the patient's mouth. Now you bent it too narrow. So when they try to put it in, it doesn't fit, or they force it in, but then it moves all the teeth. Because when the bar wants to go back to its real position, and it's going to pull the teeth with it, and they're going to start complaining that their teeth are shifting, and it's because of you not paying attention to what you're doing. It's very important. So when you're polishing, take your time, do it well, and at first polish gentle, and then you might push in a little more as you get used to it, give it higher and higher polish. So again, this avoids bending the stainless steel lingual arch wire, which is terrible. You can't do that. If you do not pay attention and accidentally bend the lingual wire, arch wire, the mora has to be thrown away and a new one made. This is a complete mother disaster. So we actually had someone come from Alabama, Talladega, Alabama, and the assistant screwed the appliance up, polishing it. No, I'm not lying to you, broke it. The patient was in pain, and so now we couldn't fix it. We had to make a new one. We had to go through the whole process of taking a new impression because the other one was destroyed, making it, fitting it. Again, it took a week to do that. So this poor lady very depressively left went back into pain, came back, it's an hour and a half drive each way, 3 hours. And the assistant did this to this patient. See, you screw up, you're going to hurt people. So you should be so fearful not to ever hurt anybody and to have kindness and love in your heart at all times so that you don't do stupid things. They say that angels fear to tread where fools rush in. So you say, oh, I can do this, let me grab it and I'll go do it. And then you bust it because you didn't take time, you didn't fear to tread. So you didn't learn and make sure that everything is fine before you touch anything. On this diagram, I'm trying to emphasize that you have a left orthodontic acrylic pad and a right orthodontic acrylic pad because you removed the acrylic from the anterior lingual bar, anterior lingual area. This is not true of all appliances, please. If there's no tooth-to-tooth contact in the anterior area, you want to avoid something called extrusion or teeth just moving. So you want them to bite into the acrylic if the teeth are not all touching at the same time. It's a complicated concept, and you should come and talk to me before you remove any anterior acrylic on people that don't evenly touch in the front. But here we go. Throwing a lot at you, and I know that. But these two pads, you hold the front of the right orthodontic acrylic pad and you hold the back when you're polishing that side. The same thing on the opposite side, and on the inside you polish it upside down. So you're not, you can move the more around any which way you want. You can polish upside down, you can polish in the front, you can polish, I even don't mind polishing the occlusal surface, just a little bit to some degree. So again, I'm emphasizing that you have to very carefully polish, you have to secure each one of the acrylic pads that you're individually while you're polishing that pad. Got it? Either on the inside of that pad or the outside of that pad or the occlusal of that pad. So you're only allowed to hold and polish the acrylic on one posterior acrylic pad at once. Please understand that. Polish one pad at a time. Finish it and go to the other one. Hold both sides, the front and back, of one pad when polishing that acrylic pad. This avoids bending the stainless steel lingual arch wire. That's what I'm really concerned about. Bending that steel arch wire, because the arch wire is bent very specially to those teeth in those positions. Now, if you know about orthodontics, you put a wire on teeth and you tighten it and the wire moves the teeth. And this lingual arch bar will move teeth. So if you somehow distort it, make it bigger, it pops into the person's mouth and makes the arch bigger. And that's crazy because, we spent all this time getting everything just right in the occlusion of the bite, and now you've screwed it up. Very important concept that you need to leave the mora, both pads and the arch bar in the same exact shape that they were before you started polishing them. Please spend time thinking about this and be careful. This is a very careful thing. This is not something to rush in. Now, if you don't pay attention, you accidentally bend that lingual wire, that mora has to be thrown away and a new one made. And if you're a real jerk, you're not going to tell me you bent it. We're going to put it in the patient's mouth. Patient's going to stay. This feels real tight. And then you can't bend it back. It's almost impossible. So you've got to make a new one. It's a disaster. And you could be a really unethical, rotten person, mess it up, put it in the person's mouth, move the person's teeth around, and never ever tell me. And then the patient starts getting bad headaches, and because the bite's off. We designed this whole thing to have beautiful, lingual cusp occlusion, tap into the specific holes, the fossas where the blue marks are made, beautiful, but then you bend it out of place, teeth move out of place, and the upper teeth no longer will fit. And there's going to be headaches, there's going to be problems. So 6 week is critical. I mean, in review, it's like, okay, do we send the person to physical therapy? Because we wait 6 weeks while they're wearing their mora for the neck to make its changes. We wait 6 weeks wearing the mora so that the neck will try to make changes by itself and want to make changes by itself. So when we go to physical therapy, they'll be ripe, they'll be ready for that physical therapy. But there are things that we do post 6 weeks, all right? And one, the POHG 13. So 6 plus 7 is 13. Crazy. POHG 13 in 7 weeks in the patient. If the patient's range of motion is normal and there's no pain, the patient's sleeping well, there's no physical therapy is needed, or they've completed it, then we're going to start weaning off of the appliance so they only wear the appliance at night. It's very important. This is critical. You have to understand this. The law, or what they call standard of care, is that at 13 weeks we wean. I don't get a choice about that. That's what everybody believes, so I have to comply. I may not believe totally, but I have to comply legally. So, we'll decide at 13 weeks. That's a special appointment. So we have the POHG 6 special appointment, POHG 13 special appointment, DF. So sometimes, if at 6 weeks we notice that we send a person to physical therapy, we take the ramps up because they know the therapeutic bite, but you, being the greatest assistant ever, notice that they're not sleeping well, and or they're getting up in the morning and they're saying, I'm doing great, but in the morning when I wake up I have problems. That means something related to night is a problem, which means we need to make a FARA, which is a anterior positioning for night. It pulls the jaw forward for nighttime and prevents the jaw from jamming into the ear, pressing the back of the joint, and the person heals. They sleep better because there's no irritation. So the DF in 2 or 3 weeks, if the mandibular range of motion is not normal. So we really get it. If this person is not moving correctly, every single visit we measure, the assistant measures the mandibular range of motion, and we want it normal. I mean, I really compulsively want it normal. And it usually is. It usually does get normal. But when it isn't, there's a reason for it not being normal. One is which is the person at night is destroying and grinding hard their muscles and joint. So we make a nighttime appliance now to give an additional 8 hours of protection. So during the day, there's 16 hours of protection. They're wearing their hard guards, their mandibular orthopedic repositioning. The joints are in their correct position. But then at night, their jaw falls back, even with the appliance in, hurts, causes grinding, and it just creates a mess. And that's not with everybody. A lot of the patients learn to go forward and hold their jaw forward when they're sleeping. So DF is another critical appointment. When do we do it? When they wake up and they say they're in pain, or they're not sleeping well, or that mandibular range of motion is not normal. We're at, let's say, 13 weeks, or we're at 6 weeks, and we're not, they've done a little physical therapy and they're still not full open. We're going to do a FARA. POHG in 4 weeks if the mandibular range of motion is normal. So we're doing the 6 week. We've taken the ramp off. We've made a physical therapy referral. We've had the patient call physical therapy right then. So the patient's going to have about 3 or 4 weeks of physical therapy, manual therapy, and we're going to see if they get better, right? So we're going to make an appointment in 4 weeks. If they're doing exceptionally well, I might do 6, but usually it's 4. But remember, we have to force them to make that stupid physical therapy appointment, because if they come back in 4 weeks, sometimes they'll call and say, well, could you tell Dr. Podolsky I haven't gone to physical therapy? And it's 4 weeks later, and they didn't do what I told them to do. And now the clock is ticking, 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 and we're not getting them better on a schedule, and it's going to run over past 26 weeks, and there's going to be a confrontation, argument, crying, accusations, finger pointing. You know, you didn't get me better. And we're like, well, you didn't go to physical therapy. And the neck is related to the jaw, absolutely. And if we don't take care of that neck, we're going to have a jaw problem. All you have to do is crook your neck to the left and, you know, and feel how your jaw feels. Your jaw, the neck has to be normal for your jaw to be normal. So the POHG in 4 weeks, if the mandibular range of motion is normal, the patient is sleeping well. So they're sleeping well at your 6 weeks. You're sending them PT, and they come back in 4 weeks. But they're still having some pain, and there's some. And at that point, we'll do a physical therapy referral. Again, if they haven't. So what does this mean? So POHG in 4 weeks. If the mandibular range of motion is normal, the patient is sleeping. So we're at POHG 6. They're sleeping well. If they're having a little pain, we're still going to make the referral to physical therapy, but we'll make the appointment in 4 weeks, waiting for that. It's a kind of a confusing line, but basically it says they're coming in. They're sleeping well. We're not going to make a ferret because they're sleeping well. They're still having a little pain, so let's do the physical therapy, because the physical therapy might get rid of this without us having to do anything. Something that I shouldn't really have to say, but I do. I mean, yesterday we had one assistant just half brain dead, and the assistant is supposed to clean up and finalize everything that's needed related to this POHG6 appointment. It involves with the notes and cleaning up and reappointment, and all this stuff has to be done. You know, I walked into the operatory one yesterday, and the models from the previous patient are still on the countertop. I mean, I don't know what to say. To me, it's insanity. To me, it's third grade stuff. You know, wipe your butt with the toilet paper and flush. Don't, you know, clean up the operatory, put the models back in the cabinet when you're done. But this is the cleanup sequence. So I'm just gonna run down the, you know, step by step the things that are supposed to be done. Sounds crazy that I'm doing it, because I would think that you'd know how to do this, but I'm making it obvious here. So at the end of the POHG 6 appointment, you have to clean up everything, get ready for the next patient. Throw the blue horseshoe articulating paper away in the regular trash. Remember, you have to have the blue articulating paper. Patient sits down, tap, tap, bites into the mora, the hard guard. Those blue marks are sacred. You don't touch the blue marks, and you cut away the ramps and thin everything, leaving the blue marks on there, right? But at the end of the appointment, of course, you throw the blue horseshoe paper, articulating paper away. You know, throw the plastic disposable 3-way syringe tip away in the regular trash. We use that to blow on the appliance to dry it out before we take a bite with the blue horseshoe articulating paper. Throw it away. Take it out. Learn how to press down and pull it out. Throw the white paper bracket table cover away in the regular trash. We didn't use any blood on any of these things. There's no blood. Throw it away. Remove the clear plastic headrest cover and throw it away in the regular trash. This is really, really important. I don't know what else to say. The headrest cover should be replaced at every single patient. I will walk in the room, and there will be no clear plastic headrest cover, you know, on the headrest. And I'm like, okay, so let's say you get the coonies, you know, you get these little mites, or you've got whatever lice. One patient comes in, it gets on the headrest, and it gives it to the next patient. We're supposed to be hygienic. I mean, I don't know why I'm saying this. It just seems obvious to me that you take off the clear plastic headrest cover, throw it away in the regular trash, and put a new one on, right? Remove the LO4 handpiece burr from the laboratory handpiece and hand clean it with alcohol, rubbing it in an alcohol 2x2. Clean the acrylic out, clean the blue out, clean that LO4 handpiece burr. Learn how to unlock it from the laboratory handpiece, pull it out, you want to put a new one in. Place the clean LO4 handpiece burr in the white burr cold sterilization container in the sterilization room. We don't want to use, we're not supposed to use, we will not use the LO4 from patient to patient, right? LO4 is the TMD handpiece acrylic burr that we use, right? So alcohol, that laboratory handpiece, that's probably overdoing it because we don't put that in the patient's mouth. Place the mirror and explorer from the 2-pack sterile pouch in the cold sterilization. A 2-pack is supposed to be open on the bracket table on top of the white bracket table cover, right? Before we started. All right, place the articulated master models back in this patient's laboratory pan. Place the laboratory pan in the operatory 1 cabinet. So you have to open the cabinet door, put that in, and get it out back into the general circulation. You're going to put it back in the lab next morning. Place the laboratory pan in the operatory 1 cabinet. As I said, clean the cabinet counter behind the dental chair. Everything has to be very, very clean. Lightly spray down the chair with the Virahol. And remember now, this is not a surgical procedure, so you have to be crazy. I went into a room the other day, and it was soaked with the Virahol. And the girl's like, yeah, I really clean it well. And she's got loads of this Virahol all over the place. And yeah, I understand. I applaud her wanting to be clean, but you don't want to overdo it. If a candy bar is $1, you don't want to pay $5 because you think it's a good candy bar. I mean, that's just crazy. Candy bar is a bad analogy. Place a new clear plastic headrest cover on the headrest. Place a new white paper bracket table cover on the bracket table. Sweep the floor of all acrylic shavings. On the POHG6, we remove the ramps, and there's shavings everywhere. Listen, by law, we have to be hygienic. That's what you do, right? Then you want to put the oh my God, bib holders on the back of the headrest cover. This is one of the things I have problems with. These bib holders, little change, they're all over the place. Come on, they're supposed to be in the back of the headrest cover. They hang off of the chair. They wouldn't be on the countertop. They wouldn't be in the cabinet. They wouldn't be in the drawer. They're hanging off the back of the chair. Put everything back to where it belongs. And each one of us will know where everything is. This is our system. So it is what's called standard of care, which means that which any good dentist would do, almost all dentists would do. And I like to call it the law. So it's the law that we write our notes contemporaneously. In other words, right then at that appointment, but never more later than the end of that day. I think every dentist in the United States will agree that notes should be written that day. We're busy, man. Very, very busy. And the doctor has to answer telephone calls from other doctors. Doctor has to check prophies even though he's not supposed to. Doctor has to help the other associate dentists. Doctor has to see CNTs. Doctor has to go in and solve problems when there are patients that are not doing well. Doctor has to deal with the front office people and scheduling. Doctors running all around, can hardly do everything, backed up in the reports, backed up in the physical therapy reviews, all kind of stuff. Guess what? You, the dental assistant, only have one thing to do. Take care of that patient for that 1-hour appointment. That's all you do. You don't do anything else. You're really not supposed to leave that operatory, and when you do, I'm sorry, You're not the best. We were complaining about physical therapists not staying with their patients, and you scoot out, you go poop, you go out, you grab something to eat, you go out, you talk to somebody at the front office. You're not taking care of the patient. Please stay with the patient. Notice what's happening in that appointment. You are in charge of this appointment. You're essentially the person providing the motherly care to the baby. Mothers don't just drop kids and leave them. Mothers don't do that, not good mothers. So you are going to stay with this patient. You are in charge of the documentation. Yes, the doctor will sign notes, but these are all pre-formatted notes, and then you're going to add in what handouts occurred, any statements the patients may have made. You're going to customize these notes for each one of those visits, and you're going to do it right then while the patient is sitting right there. You are going to do that. So that also the doctor will have his notes written. You're making it easy for the doctor so that he can or she can do more, focus on patient care, take great care of his patients, and not worry about like some of the things that you can take care of. Anything that you can take care of, you should want to take care of. What you say is, hey, I'll do more. I want to get paid more. Please give me more to do. It's like you are in charge of the documentation of this appointment. No question, no how, no way. Don't say, oh, I got busy with other stuff. Because I'm finding that less professional assistants are forgetting things, and they say, well, it wasn't my fault. Oh, yeah, it was your fault. You are in charge of that appointment. You have one appointment, one patient to manage for that 1 hour. That's it. You need to document it, and you need to make sure that the doctor signs those notes, preferably as soon as possible during the day, not at the end of the day. So the POHG6 notes, which are specific notes, you can go into the TMD section of the notes and pull up POHG6, and up comes the automated, pre-populated, written out notes for this particular visit. The POHG6 notes are entered into the patient's Dentrix charting module by the attending TMD assistant, not the doctor, the TMD assistant. The TMD assistant must add the names of any handouts given to the patient into these POHG6 notes at this visit and before the dentist signs the notes. So who's in charge of customizing the POHG6 notes? The assistant, the TMD assistant. Who's in charge of pulling up the charting module? The TMD assistant. Who is supposed to populate the POHG6 notes into this patient's charting module for this day? The TMD assistant. This should all be like pretty obvious. And it is critical because the dentist needs this documentation, one, for legal purposes, two, so that later when the patient says, oh, I never got this increasing range of motion handout, well, you have it in there and you put it in there and it's documented that you gave that handout to that patient. Or if the patient says, no, I just haven't felt like wearing the appliance, you put those in quotation marks. Patient stated she is not wearing the appliance per instructions. You always have to remember that the notes you pull up and customize in the charting module are not final. The dentist can change them, update them, add or subtract things, and they're not final until the dentist signs these POHG6 notes later in the day or right there at the end of the appointment, which would be really optimum. The TMD assistants help the doctor by entering the pre-formatted notes into this patient's Dentrix chart, and this really significantly reduces the dentist's work and stress. And basically, the dentist is your racehorse. You're taking good care of that dentist because that dentist provides you income. That dentist also needs to keep his attention on his patients, needs to use all of his thinking powers all of his brains for solving problems to improve this patient's life. That's what that doctor's doing, and you're part of that doctor's team, and you're taking away things that you can do from the doctor's thoughts so that that doctor can be efficient at helping. And really, I need this. I really, really do. And I just think it would be outstanding if you do adopt me as your child, because I need that. And this is one of the simple things. Really, it's you should, after you do this a little bit, you'll find that pulling the notes up and adding things in, customizing and helping with them, you'll become a team with the doctor, and this will be one chore less that the doctor has. He can then see more patients, make more money, and pay you better. And if anything, it's not just pay. It's like we're a team. I'm going to do my very best to do the best I can for patients. You, I hope, will want to support me in that effort, and that I will in turn support you in your life through work. So what are these pre-formatted notes that you're going to populate or put into the patient's chart? What are they? Well, they're the Dentrix POHG6 notes. You're going to go pull up the charting module and make sure it's this patient that you're at. Go into TMD, go into POHG6 and double click it. Up they come. What comes up? Postoperative hard guard at 6 weeks. Mandibular range of motion measurements taken. The patient presented and filled out a TMD patient self-evaluation form. The TMD assistant reviewed the TMD patient self-evaluation form with the patient to clarify the patient's written concerns. All questions were answered for the patient. Patients able to consistently find the therapeutic bite position. The lingual guide planes were removed, adjusted the right, left, and therapeutic bite positions on the mandibular orthopedic repositioning appliance, checked the lateral side bends of the head, referred patient to physical therapy to improve cervical head range of motion. So these are the notes as of like August 2020. They'll probably change and be updated and added and be more precise. And as we get better and better and better, we'll add additional things on. But these are the notes that pull up, and let's take a moment to review each one of these lines so that you'll understand them and you'll understand when they should be modified, and also use the notes as a guide to doing everything that you are required to do at this appointment. Got it? The notes are going to teach you what to do at this 6-week appointment. And I can't reiterate over and over and over again. We treat patients based on the number of weeks they have worn the hard guard. And we have, this is 6 weeks after wear of the hard guard. Certain things we expect to happen and certain things we must do based upon knowing how best to treat these patients. And you are in charge of helping me so that we'll execute this step-by-step protocol. Protocol is step-by-step ahead of time, things that you do, so that we get excellent results and patients are taken care of really, really, really well. So the first notation is postoperative hard guard at 6 weeks. This is really important. First of all, you need to know how much time has passed since we have delivered the hard guard. You know that by looking at the bottom of the TMD patient self-evaluation form. Hopefully, the front office people who did the pre-appointment review the day before filled this out correctly and circled the amount of days that you don't have to do it. Technically, the assistant, TMD assistant, should not be the one calculating how many weeks go by. It should be the front office people. But so often the TMD assistant loves the other staff member more than the patient, more than the doctor, and tries to cover up the fact that something wasn't done properly. But the number of weeks since the hard guard delivery is indicated on the form. It's extremely important that you understand this because you're going to ensure that what has to be done at 6 weeks is done at 6 weeks. Who ensures this? The TMD assistant. So this POHG, post-operative hard guard, is done at 6 weeks after the delivery of the hard guard, not the soft guard. The treatment clock begins with the delivery of the hard guard. I'm very kind to patients. I don't include the soft guard period. You have to look in the patient's dentrix ledger to identify the date that this patient's hard guard was delivered. That's how we find it. Hopefully it was done the day before. If it wasn't, you need to make it your business to do it right now because we may not do the POHG 6. We may do something wrong. And whose fault is it? I'm sorry, look in the mirror, take a good look. It's you because you're supposed to ensure that what we do at each POHG is correct. So you make it your business to know how many weeks has elapsed. If you look down on the patient self-evaluation form, it's not filled out, do it right away because you need to know what do you got to do for this particular visit. And again, there are several things that we expect to be done or expect to happen at 6 weeks of more aware. We expect that the patient knows the therapeutic bite, right? No problem, goes right to it. We also expect that, the patient's neck is improved or is having problems because it wants to improve but can't, and then we're going to have to make a referral. We need to make sure the patient has been wearing the appliance. We know that by the patient putting it in and taking it out with no effort. Certain things have to be done, particularly knowing that the patient knows the therapeutic bite, has adopted it, and goes there very quickly every single time. This is critical for you to evaluate at every single appointment, but at POHG 6, it is super important because you're going to determine whether we're going to take those ramps off today. And we should take the ramps off today if it's 6 weeks. If we go longer, there could be problems. So very important, please pay attention to how many weeks have elapsed since that DHG. It's your business to know that. The TMD assistant must know that this appointment is at 6 weeks. And sometimes it's 5 and sometimes it's 7, but we want to get that appointment in at about 6 weeks. That's why when you make appointments, 1, DHG, 2, POHG1, 1 week after delivery of hard guard, we want to see that patient, right? You know that? Then 5 weeks later, which is total 6, because 1 week after is 1, plus 5 more is 6, 5 more weeks later, we need that POHG 6. You make the appointments that way. You actually make your appointments that way so that we see people at these critical times. And if you look at the bottom of the numbers on the DHG line, you'll see there's an underscore at 6 weeks. And that means, hey, pay attention. We have certain things we have to do. Be sure they are done. So if you don't look at the form, you're going to screw up. If you don't fix the form as if it's wrong, if the number of days is missing, you put it in because you need to know, inquiring minds need to know how many weeks this patient has been wearing this appliance. So the name of the visit is post-operative hard guard at 6 weeks. We expect it to happen at 6 weeks most of the time. Sometimes it'll be 5, sometimes it'll be 6. We don't like 7. I am extremely proud of what we do. When I first learned how to make mandibular orthopedic repositioning appliances, I put them in. And I was aimed at getting rid of pain, and I did that really well. But as I get older, smarter, more purposeful and wanting to help people more, I started realizing I don't want to just get rid of pain. I want to restore function. I want to restore full health. So taking the mandibular range of motions, to me, helps me monitor if I'm being successful at achieving optimal health. I usually get rid of pain at 6 weeks, but I'm proud that we take mandibular range of motion measurements at every single TMD visit. Just get that in your head. Remember that forever and ever, because a lot of times they'll come up and say, well, they're coming in here today for a JRT. Do I take the mandibular range of motion? Yes. Oh, they're doing a follow-up visit after, their soft guard. Do I take mandibular range of motion? Yes. We do it at every visit. Every means every visit. Our goal is not just to eliminate our patient's pain, but to also restore full, optimal mandibular health function for this patient. So the normal lateral movements, right lateral, left lateral, are 8 to 10 millimeters. And normal opening is 40 to 50. And this is what we're trying to achieve in every single patient. So one of the things you do is you fill out the bottom part of the patient self-evaluation form in a sticky. You fill these things out, and then you bring them to me wherever I am in the office. And some of the assistants don't understand this. So you're going to bring this patient self-evaluation form to me, and I'm going to look at the mandibular range of motion. Like if I see 40, 50, 8 to 10, I'm a happy camper because I know if you build it, they will come. If we restore the mandibular range of motion continually, the patient will heal. That's what I feel like, right? If you walk correctly, you're probably going to be fine. So it's critical that you become an expert at doing this. These measurements, these mandibular range of motions, are written on a yellow sticky and placed on the top of the right-hand corner of the patient's self-evaluation form. I do it because, put it on a sticky because I need to check it. You're just you're learning, you're a lay person, you're not an expert yet, particularly on most of my assistants. You can record it incorrectly. That actually happened yesterday. And my gut hurts, and I'm not lying to you. It makes me nerve-wracked because behind my back, people do things. I am so OCD about being the best dentist in the world. I want to be the best, right? I also want to avoid a lawsuit. I don't want any confusion in my work. I want my work to be perfect. So one way that I keep my work perfect is if I make sure that I check everything that you do. So you put on the top right side your mandibular range of motion measurements. And then once I approve them, you will transfer them to the form and sign the form. Remember that. You sign the form after you transfer the measurements. Yesterday, we had a person incorrectly totally mess up the measurements and did not put it on the sticky. Wrote it permanently ink on the form incorrectly, not even close. Like, I think she said like it was like 4 or 5 millimeters, and it was 10, or it was incorrect. And then I had to go back and what we call doctor the form. I had to write a line through there, put the correct measurements in, and that a lawyer has a field day with that. The lawyer says, Dr. P, are you changing things after the fact to correct your errors? Dr. P, do you modify things? One of the things that is really important in notes is you're not supposed to doctor them or change them after you've written them. That's a key in dental malpractice law. So the fact that she did this is just a huge betrayal, and you can't do that. So again, we take mandibular range of motions at every single visit. They're put in a yellow sticky, and at dismissal, the assistant is supposed to be sure that they transfer those numbers, sign the form, make sure the whole form is correct. Very important. So as you know, the notes are things that are permanent records, meaning 10 years from now, we can read what was done on that day. The notes are like a movie in writing. It's very important that you understand that. The notes are legal. A lawyer could look at it. Notes are legal. It could be looked at by a review. There's a lot of things. It's serious. Notes are the only way that an investigator can go back and see what the doctor did. Notes also have importance. So we're going to look at this particular line in the POHG6 notes, and we're going to start thinking, okay, what are the consequences of these notes? Okay, what can happen with these notes? Because you may not be thinking like a lawyer or an investigator, but you should. All right, so here it says the patient presented, which means they actually showed up for the appointment. So you can't put those notes on if they didn't show up. Sounds crazy, it's happened. There are some crazy people in the world who do things without thinking, but the patient actually showed up, and we can go back and see that they had a sign in with their routing sheet. Now, there's a paper routing sheet that we keep on every single patient. Make sure you get that routing sheet. And so the patient presented, means they showed up, they checked in, they signed in, the sticker was put onto the Dentrix routing sheet, and the patient filled out a TMD patient self-evaluation form. So an investigator, an attorney is going to want to see this form. And if you don't give that form to the attorney, he's going to make you lose the case. That you're stupid. We did a form. He's going to say, where the hell is that form? Where did you put it? Patient said something, you didn't do it. We know that because you lost it, and you lost it on purpose because you don't want other investigators to see the bad work that you do. Now, listen, that's not true, right? But it doesn't matter. That's his job to make me look like a monkey. And if we lose this form, I am a monkey because we say in these notes that we have a form. He's going to be looking for the form. You can't lose the form. You can't lose the form. You scan that form into that patient's Dentrix Document Center that day, if not right then at the end of that visit. And I think we're going to make that our responsibility. So the notes tell the investigator we have a form. If we can't produce the form, we're stupid. I don't know. All right. Do you get this? The notes say there is a form, so someone's going to go looking for the form. You have to save the form. And it also says that, we're directing our care at the patient's concerns. We are very concern-loving people, but we're not loving if we lose these forms. So here's one of the kickers. This is the note. These are the notes. These are the legal notes that the attorney's going to look at. He's going to say, where's the form? It says that you had a form on this POHG6 date. I'd like to see what the patient said during that day. Do you have the notes? No, I lost them. Oh, so you lose things. That's great. Let's go to court because I'm going to beat the heck out of you and win $2 million because you're stupid and I know it. Because a good doctor saves the notes. The good doctor saves everything related to it. You hear me saying this over and over again. It should get in between your eyes and your ears and your brain that you are in a somewhat dangerous situation because, we got patients to heal and make better, but then we have a subset of patients that are going to come back and sue us. They're going to say we're jerks. It happens. People get divorced. So these notes have to be good, and there's a reason for every little thing we have in these notes, and everything that we do to show the lawyer, to show the investigators we are really competent. And I'm unusual because I assume that I'm going to be sued. I assume it. So I want to be ready when I'm sued. Isn't that crazy? And I think I'll be safe if I think like that. Safe, because everything is wonderful. And so when I go to battle, I have all my armor, I have all my men, I have all the horses, I have everything I need to go into battle and win. So the next line is the TMD assistant, get this word, reviewed. What does that mean? You actually looked at the patient self-evaluation form. I can't get people to do this. They don't read it. They don't. I mean, you're supposed to read it, right? Duh. So you read it, and as you get better, you'll become certified to answer questions in this form. We are supposed to respond to every single question, comment that the patient makes in the TMD patient self-evaluation form. Please, I'm excellent. Other dental offices don't do this, and I mean it. So this form is a key secret to my practice because I am dedicated to my patients. I don't want a patient ever to say that I didn't do well. And get this is wonderful, because 2 years from now we get sued and there's an inquiry and we pull these forms out and we answered all the questions and it shows it in the notes. We're good. And the patient says we're good, but 2 years later they sue us. We pull all these TMD self-evaluation forms out and it's saying we're great. They're doing great, So the TMD assistant reviewed the TMD patient self-evaluation form with the patient to clarify. That means to make it clear the written patient's concerns or the patient's written concerns. So as you never talk about things you don't know, you do talk about things that you do know, and you should learn what they call the originations. These are the things that patients typically write on these forms, and how to educate the patient to answer their questions, to answer their needs. A person could say, well, I have pain when I eat. Well, guess what? That's a common thing, because when you take the appliance out, the mora out, the joint goes back and crushes the back, and you have pain when you're eating. Now you have to eat with the mora in. Well, this one question answer, you're going to be telling this to hundreds of people in a couple of years, because it's a common origination, right? You should learn the originations, but never give your personal advice ever. Always refer to, and we have a text that gives you all of the answers to all of the originations, and so you can answer them correctly. You are ministering to the patient like me. We're supposed to be a treatment team, and I can trust you to give correct answers and responses, but I want you to do as much as you possibly can legally do to help me provide extra care, extra love to this patient. And it's legal. So we put this line in, but the lawyer is going to dispute it. All questions were answered for the patient. So we have the patient TMD self-evaluation form, we review the originations, and we answer any questions for the patient, and we really, truly do that. Please, you should do this. Look what I'm saying. I'm saying here in the notes that you and me are answering all questions. Are we really doing that? Are you ethical and honest? I'm writing this in the notes. Are you doing it? Or are you just like sitting behind the patient? I see that. One particular assistant, she stands near the counter behind the patient, and there's no interaction with the patient. And when the patient's here, we should educate that patient at all times. When the patient's here, patient's paying money for this visit, it shouldn't be annoying to you. The visit and patient should not be annoying to you. Should not be annoyed by the patient. You should interact with the patient. Take that opportunity to teach them a little bit about TMD, or interact with them as person to person, but you're never allowed to invite the patient home or go out with the patient or give the patient your telephone number or sell the patient anything. That you are in a professional situation, right? Very important. We've actually had that. We had one dental hygienist that was dating several patients and I didn't know it. So she was soliciting them in her chair. And that was highly unethical. And then she was fired. But it's crazy. But we want to be the best in the world. We love our patients. We want to make sure that they're happy and that all their questions were answered each time they came in. So this is what we're putting in the notes. It should be true. You should make it true. One of the reasons that I feel it's important that you learn how to make moras and do JRT appointments is that you'll understand the concepts and the ideas, and you'll be able to duplicate them. And this is extremely important. I mean, it's extremely common for me to walk into the room and the assistant never evaluated if the patient can bite into the therapeutic bite. You need to learn that. You must do that. Inside the form, it says patient understands and can bite into the therapeutic bite. That means you're going to have to start looking at where this patient's therapeutic bite is. You must have the models articulated, hand articulated on the counter to see where the therapeutic bite is. Then you have the patient bite into the therapeutic bite, and you ask the question, are they going into it right away without slipping, sliding? You're supposed to do that. And at the POHG6, we're not supposed to take the ramps off if they don't know their therapeutic bite. But you could be a doom and then not say that to me or leave it, and I'm assuming that they can bite into their therapeutic bite because you haven't said anything. Or you'll say, yes, they can, because you just want to say something, and you're a liar. And now I'm adjusting the appliance based on a liar's comments. You can't do that. So it says the patient is able to consistently find the therapeutic bite position. You have to stand in front of the patient, have the patient bite several times while you're carefully watching. And the patient should go exactly each time consistently to the therapeutic bite. If they're hitting somewhere else and sliding, most often they're going back and they hit back. They never learn the therapeutic bite. There is a problem, major problem. And they can't get better if they take the cast off their broken leg all the time. They're never going to get better. And this is if they don't go into the therapeutic bite every single time, they're never going to get better. And that's your job to make sure that happens. That's your job. Your job to take mandibular range of motion measurements. It's your job to make sure the therapeutic bite is there. Your job to make sure they went to the physical therapist if they were sent. Your job to help. Your job to heal. It's your job. The entire purpose of wearing the mora is to keep the patient's mandible, the lower jaw, and both temporomandibular joints in their ideal position, in an ideal position. If you build it, they will come. So you make a wonderful anatomical situation, and everything will heal. That's what I believe. If the patient automatically stays in the ideal position at the therapeutic bite, the patient's going to heal. I believe that. I really super believe that. There are some exceptions, but extremely rare. 1 a year, 2 a year at the most, and we see hundreds of patients, hundreds and hundreds of patients. Therefore, it is of the utmost importance that the TMD assistant ensures, ensure means like guarantee, you are making absolutely sure you know what the hell you're doing. I'm giving you so much authority, and that's an honor. Don't disgrace yourself by not doing things correctly. Ask questions, learn. This is in life, I think it's important to learn always. Also learn when you're not right. Learn to relearn things when you've learned them wrong, right? Therefore, it is of the utmost importance that the TMD assistant ensures at every visit that the patient is indeed biting into and staying at this ideal healing position, the therapeutic bite position. It's your job. So again, it's, we're telling the attorney or the investigator, or even me, I want to go back. You'll see me look back and see what we did. So I'll open the notes. These are the standard notes. You will add stuff to these notes. You will open these notes up at the beginning, beginning, beginning of the appointment. Don't wait. Open the notes on Dentrix for this appointment. It's a POHG6. Seat the patient, take the mandibular motion, go over to a computer and open the charting module and add POHG6 onto the notes at the bottom, clinical notes. So the lingual guide planes are removed. We don't need them anymore. The patient has learned how to bite in the therapeutic position. Don't need them. Next thing is adjust the right, left, and therapeutic bite positions on the mandibular orthopedic repositioning appliance. We are balancing out the bite, the occlusion, We're removing the lingual ramps. She doesn't need them anymore. And the patient can move more freely because the obstructions of the lingual ramps, which were teaching ramps like training wheels, I call them training wheels, they don't need to be there. And it's really important that they get removed because they are harmful if they're worn too long. Just remember, lingual ramps are harmful if worn too long. Very important. The way the synovial joint's one that has synovial liquid lubricant in there, and the temporal mandibular joint is a sac with liquid in it, very slippery, slidey liquid. And that liquid has to move in order to nourish the inside of the joint. So again, the lingual guide planes or the railroad tracks are only removed when it has been confirmed by you, by me, that the patient automatically knows the therapeutic bite. The ramps are there to learn the therapeutic bite. And once they've learned it, we don't need the ramps anymore, right? If they haven't learned it, I'm upset. I'm extremely upset because they're not going to get better, and I know that. So once the patient knows the therapeutic bite, there's no need to retain the ramps. The lingual guide planes can be harmful if worn too long. We want them off. The temporal mandibular joint gets fed when the synovial fluid inside the joints moves around, swishes around. That's how it gets fed. In other words, we have blood vessels pumping blood through us, and the blood feeds everything. Well, the blood does not go into the temporal mandibular joint. The synovial fluid goes in. So the synovial fluid acts like the blood and feeds everything. And there's no circulation, so the blood goes through because the heart's pushing it. But there's no heart in the side of the synovial joint. So the only way the synovial joint gets better is movement around, swish around the synovial fluid, so it will feed all of the parts inside there. So the temporal mandibular joint gets fed when the synovial fluid inside the joint moves around. This is done with mandibular movement. So removing the guide planes allows more mandibular movement. We do that once. It's only used to teach the patient the therapeutic bite. Once the patient knows the therapeutic bite, we get rid of it. You should understand absolutely what 45 degrees is. And we're going to start with 90 degrees, which is a right triangle. It's like the corner of a house, corner of a book, 90 degrees. 45 degrees is half of that. So learn that angle, 45 degrees. We have a big plastic protractor that you can use if you really need to, and you should when you first start. And you're going to check the lateral side bends of the patient's head. So the patient's going to be sitting, keeping their shoulders straight across, and just moving directly to the right with no twisting of the head, and directly to the left. So it says, check the lateral side bends of the patient's head. Should say record too, but we're going to record it. We're going to put it in there. Normal lateral head range of motion is 45 degrees. Be sure the shoulders do not move and are straight across, or they're not pulled up. So sometimes shoulders stay there, they're bending to the left, and as they bend to the left, their right shoulder comes up, and that's not a real bend. It's the shoulder movement, the whole shoulder's moving. We want to see the head moving, only the head. So be sure the shoulders do not move and are straight across. Do not let the patient tilt the head backwards or forwards. It's a straight side bend when recording the lateral side bends. This is important because it's going to tell us, are we going to make a PT referral or are we not? Got it? This is my call. It's the doctor's call. But you're going to be good. Because you only got 10 degrees, we're going to PT. Write it. And most of the time you can write it. Just go ahead and write it because we can always rip it up. If you do write it, I complete and sign it, scan it. It has to go into the patient's document center. Extremely important for legal purposes. The physical therapist could totally screw up the patient badly and then say what we told her to do, this, that, or the other. And we didn't, we didn't. So there you go. Make sure that you learn how to do that. Usually I'm the one that does it, but as you get better and you learn what 45 degrees is and you learn how to move the head, you're going to be able to do this for me And hallelujah, I want you to. And it's not a big deal. And even if it's not needed and you refer to PT, it helps. It makes everything a little bit better. Now, I'm not saying that we want to refer patients who don't need PT to PT, but I almost feel like, this is crazy, almost all patients with TMD have a neck problem of some sort, even if it's minor. So they would benefit from PT. PT is also covered by medical insurance. So it's usually like $180 a visit. The insurance pays amount, patients copay 25 or $50. Not bad. And it's good. And PTs are good because they address muscles, ligaments, right? And joints. The chiropractor just does joints. So and there's a need for a chiropractor, but we refer to PT, not chiropractic, at 6 weeks. So again, the notes here say referred patient to physical therapy to improve cervical head range of motion. This is a referral. We write a prescription. Legally, we have to record we gave them a prescription. It's the law. It's the law. You give them penicillin, it's the law. You got to record it. You give them codeine product, narcotic, it's the law. You got to record it. When you make a prescription for physical therapy, it's the law. You got to record it. It's your responsibility as the assistant. I'm not going to sit there and have to watch everything you do. You have to do this without any request. You have to, and so you have to understand the importance of these things. So it's referred patient to physical therapy to improve cervical head range of motion. It is extremely important that you properly complete the physical therapy prescription and scan it into PDF because that's how we store it permanently. We don't store it as paper. We store it as electronic in the chart. So it's extremely important that you properly complete the physical therapy prescription and scan it as a PDF into the patient's Dentrix document center. It's a permanent record that we sent it. The PT referral is a legal document, meaning that a lawyer might want it because the lawyer is going to say, what did you refer this patient to? So let's say something terrible happens and the physical therapist is a jerk and starts working on the person's hips, right? And talks about incontinency, some sort of urinating and all kind of crazy stuff that we did not make the referral for. Then someone sees this and says, a dentist referred for vaginal problems? Wait a minute. And so it sounds crazy, but this could happen. And then we go back and we pull the physical therapy prescription and it shows clearly that we restricted it to cervical or neck issues. Very important. Very important. Has to be scanned. This is your duty. This is your responsibility. And you should do it right there at the end of the appointment or during the appointment. This is your responsibility. Now, this sounds crazy and honky, but patients sometimes leave. I've had patients, this is true. We had one patient, we were going to make her a FARA because she was had sleeping issues. And then like 6 months later, she comes back and yelling in the office, and I mean threatening yelling. And she said, you promised to make me a new hard guard. Well, she lost her hard guard. And there's a charge for losing the hard guard. I had agreed to, and I do this a lot, to do a free mandibular modified FARA. But she interpreted it as a new lower. She lost her lower. I didn't see her for 6 months. She just disappeared. And it's like, oh my God, she disappeared for 6 months. Did we do that? Who's responsible for that? Well, some people may say she didn't make the appointment. She didn't show up. It's her responsibility. Some other people would say, well, if a child's having a problem, it's the mother's problem because the mother failed to act to take care of the child. The mother is the one that's going to be taken care of by family services, not the child. Child doesn't know enough. So this person didn't show up after 6 months and then got into a major out-and-out shout match that she was going to get a free lower mandibular orthopedic repositioning appliance. And it's like, no, she wasn't. And we didn't do it because she was nuts. But I don't want to lose patients, and I also want to show the lawyer I want to show that attorney I'm good. I made an appointment. She didn't show up. It's her fault. I want to mitigate, lessen all the lawyer stuff at me. I want to show them I care. And I'm going to document it in my notes how much I care. I make sure that every single patient, I really do, and you do, gets a new POHD appointment. We said a new POHD appointment was scheduled. It's in the notes. It must be true. You are writing the notes. You must do it. Patient doesn't want to make that appointment. You go haywire. You go nuts. You talk to the office manager. You talk to all the receptionists. This person needs an appointment, because what's going to happen is if you don't make that stupid appointment, they're just going to forget. They'll come 6 months later. They won't be in good shape, and they're going to blame you totally, blame me totally. It's happened. Don't say it doesn't happen. So I'm putting this in the notes and you must do this. You're ordered hereby to do this. It's in the notes. You must do this. Make a new POHD appointment at every POHD 6. And an appointment card was given to the patient. Now, this is where a lot of stupid, very bad, stupid means, I guess, ignorant more, to ignore something. Staff are lazy, and I like to give cards at the drop of the hat for anything. Why? Because people are going to forget my name. They're going to forget the telephone number. They might be with a friend, and they got that card in their pocketbook, and they open and show the card to the other patient. Patient calls. Wonderful. Or the patient needs to call to cancel. They forget our telephone number. You pull up the card. There it is. Lots of cards, because every time they come, they get a card. On the back of the card, the new appointment's there. We had someone walk in a day early. It's a 2-hour ride here from South Georgia. 2-hour ride, walk in a day early, and got mad at us. So the receptionist, being smart, said, "Do you have the appointment card?" And so, yes, hallelujah, pulls out the appointment card, and sure enough, it's for Wednesday, not Tuesday. And that particular time, I was slammed with 4 patients. Normally, I would do everything I can to assist, to help them. They came all that way. But it just didn't happen. It couldn't happen. So all the blame went on the patient. Hallelujah. And I'm not in trouble. All because a very competent, excellent, well-thinking, concerned assistant wrote on the back of the card the appointment date. And that's what you have to do. You're ordered to do so. So you always make an appointment at the end of every POHD 6 or every POHD. And you always give an appointment card so that there be no confusion. And there'll be several appointment cards in the patient's pocketbook. They're always going to remember the telephone number. And if any friend ever asks where they're going, because they've got 2 or 3 of these appointment cards, they'll pop one out and give it to their friend, and the friend will come in. So you're doing good for me. So we really care about our patients, right? We really do. And we need to think of ourselves more like a professional baseball team. When we put a pitcher in, we want that pitcher to be successful, strike everybody out so that we can win the game. If the pitcher sucks and they're getting home run after home run, we pull the pitcher out and put a new pitcher in. Because the coach wants to win. The team wants to win. The TMD assistant will now monitor, it means watch this patient at every visit after a physical therapy referral. We want to see, is the patient doing well? And if the patient's not doing well, we pull the pitcher out and put a new pitcher in. This is what they do in baseball. This is what we have to do. This is our baby. These are our patients. We need a new physical therapist who cares. I had one extremely arrogant physical therapist who got no results after 2 months. And it's like, I asked the patient fell in love with the physical therapist, no results, bad pitcher, losing all their games. And then she arrogantly told me that mobilization is not as important as stabilization. Wait a minute. You need to move, the neck is frozen and twisted. You need to first get it into normal position, then you stabilize the normal position. But if it's out of normal position, you can't stabilize it. That's crazy. And no results. So the TMD assistant will now monitor this TMD patient's physical therapy progress during every subsequent visit until the final TMD patient dismissal. So you're going to do the side bending of the head along with the mandibular range of motion, and you're going to record it at the bottom of the TMD patient self-evaluation form in the area, including the following: measures cervical range of motion at every subsequent POHG or POF post-op FARA, modified FARA appointment. And then you ask the patient, how do you feel about your physical therapy? And so the patient says, well, I didn't go. Oh, please, you need to put that in the notes. Patient didn't go. Patient did not go. Patient got a broken foot, doesn't want to put the cast on. Patient is not going to go to a certain level of improvement, which they may be happy with, but then they're not going to get optimally better as they could be. So how does the patient feel about physical therapy? How do you feel about your physical therapy? And you ask this. And if they say, oh, it's great, I just love, Molly, she's great, or whoever it might be that you are the patient's going to, we need to see the results. We need to see, are they doing well? Are they going? And we monitor this. We ask these questions at every single time in the bottom part of the TMD patient self-evaluation form. It's there so that you will ask the questions, check the progress. Let's see how we're doing. I want a report card at every single visit. A lot of dentists just throw appliances in for real. They'll put this, here you go, Mrs. Jones. Here's your TMD sleep appliance or whatever. And they'll put it in. And let me tell you, 2 years go by and they never check it. They don't even know if it works, right? They don't ever ask the questions like, well, I just got my $1,800 and I'm happy. I don't need to deal with that. Anything it's the same with sleep physicians. Very often they'll put CPAPs in and they don't do studies to follow up. But here we go. This is just the way it is. At every single visit, we want to monitor the success of the physical therapy by taking lateral, side bend measurements and asking the patient, how are you doing? How do you feel about your physical therapy? So we're going to summarize the 6-week TMD POHG6 appointment. This is an appointment that is managed by the TMD assistant. The TMD assistant needs to be aware of what is necessary, obviously. So let's just review it. The patient arrives and fills out the pre-prepared TMD patient self-evaluation form in the waiting room. With COVID, we've been putting people in rooms to get them out of operatories. But the key and most important thing is that form is filled out before you seat the patient or before you touch the patient. And I'm going to repeat that. As the TMD assistant, you should ensure that that form is correctly filled out. The referring doctor's name is on there, patient's name is on there, and you ensure that the patient filled it out. You look at it, take a look at it, right? Right? It's like, keep it simple, stupid. Look at the form. Oh, you missed this area. Could you please fill this one out? Right? So you have to manage the patient to fill out the form. After confirming the patient is in the office, the TMD assistant pulls up this TMD patient's Dentrix charting module and clicks on the POHG6 notes. So in the charting module, we write notes. The doctor writes notes, but the assistant is responsible for pulling up the notes for each visit. And the doctor simply goes on there, checks the written information, and then signs off. So the doctor ultimately signs off finally, but the assistant, who is excellent, writes notes. And guess what? This is a very specific visit. This is the POHG6. So there's specific notes for specific things that have to be done. It's already up there for you. And all the TMD assistant has to do is customize. So if the patient says, "Oh, gee, I can't go to one of your certified, physical therapists," that has to be noted. If we give them a handout, let's say de-allergizing their bedroom, that has to be noted. All the stuff that we do has to be noted. The critical thing at POHG 6 is two critical things, but one, we take off the lingual ramps, the railroad tracks, and we send them to PT to get their neck handled. All right, next thing is patient is seated and the TMD assistant checks that the mora is in the patient's mouth. Guess what? Patients lie. And it's funny, I was just talking to an orthodontist yesterday and he was talking about removable orthopedic appliances. He said kids don't wear them and they lie. They go through all kind of stuff with their parents. And we need to be sure that our patients are wearing our appliances because they can't get better unless they wear the appliances. Because the appliance, if you have a broken leg, you've got to wear your cast. And orthopedic surgeons are lucky because, once they put the cast on, the patient can't take it off. And I wish it was like that with us. So the patient's seated, and the TMD assistant checks that the mora is in the patient's mouth. If it's not, you have to notate that because you say patient would present it today without appliance in the mouth. Why? Patient's not complying. Patient later complains, and we say, listen, you're not doing what we ask you to do. How can you expect us to make you better? Patient is then asked to bite into the therapeutic bite position. And you just say, could you please bite down? And you look carefully, and the TMD assistant verifies that the patient has adopted the therapeutic bite. There should be no bite and slide. Patient go right into the therapeutic bite. Bang, bang. This is a whole thing that you need to learn how to do because the purpose of this therapy is to teach the patient to go into the correct right and left jaw joint positions, pull that tongue forward, and allow the patient to even swallow better. But they have to learn, their brain has to learn this therapeutic bite position, and they have to practice with exercise 1 over and over and over. And if they're not, we have to keep on coaching them. They're our kids. We want them to be successful in life, and we have to check to see if they have adopted it. So if they've come in and they've got no appliance in, we know we got a problem, right? They're not wearing it. How can you learn the therapeutic bite and put your jaw joints in the right place if you're not even wearing your appliance? Next thing, you could be wearing the appliance, but not in the therapeutic bite. So that would cause you to grind like heck. So these patients come in and they can move right and left nice, but they can't open because they're grinding and their muscles are tight from grinding because they're not in their therapeutic bite position. If the patient knows the bite exactly, which is what we hope, the TMD assistant prepares to remove the lingual ramps with the dentist's permission. So please don't go ahead and remove those ramps. I've got a lot of crazy assistants because if the patient has not learned the therapeutic bite, you're not supposed to remove the ramps. The ramps are to teach the therapeutic bite. Once the patient learns the therapeutic bite, the ramps are removed. The ramps are not removed if the patient does not know the therapeutic bite. The TMD assistant asks the patient to remove the mora. So we watch them put it in, put it out, put it in, put it out. And if they can do it with ease and flip it with their tongue and no problem, they've been wearing it. Another thing is, if they're spitting all over the place, they were not wearing it. Because listen, your brain starts knowing that the mora is not food because you keep it in all the time and the brain starts saying, this is not food, I won't make any more spit to chew with. If, however, they're spitting all over the place, they're not wearing the mora, and they're liars. They're just going to say, oh yeah, I wear it all the time. No. If they put the mora in and they start spitting, they make spit, that means that the brain thinks it's food. Why would the brain think it's food? Because they haven't been wearing it. If they wear it, the brain figures it out very quickly and stops making spit for the mora because the brain will learn that the mora is not food. Got it? The TMD assistant asks the patient to remove the mora and watch them do it. And then the mandibular range of motion measurements are taken with the appliance out. Got it? But you're going to put it back in. Please, before the dentist comes in, that appliance should be back in. That's a big problem. When I come in, I sit down, and then I have to spend 10, 15 seconds or half a minute saying, could you please put your appliance in because the assistant wasn't too bright? Uh, and I have to be delayed. I got another patient, maybe two other patients, and I'm asking them to do things that the assistant should do. A good assistant is worth his or her weight in gold. But a bad assistant is making life miserable, right? Then the TMD assistant asks the TMD patient to place the mora back into the mouth. This is very important. We're watching them put it in, take it out, and we take measurements with the mora out because those ramps prevent them from moving correctly. We want to see how they really, really, really move naturally, without the mora in, and that's how the measurements are taken. Okay, it's 6 weeks, as I said, and we're continuing on the incredibly wonderful TMD assistant's responsibilities and duties. And the TMD assistant needs to know this stuff down cold. That's why we're doing this course, all right? And the next thing is the TMD assistant takes the patient's lateral head bend. So the shoulders have to be back. That when they're bending their head, the shoulders cannot come up, right? Because a lot of times they squinch their shoulders up in order to move their head. That we don't want that. We want to see, can the head side bend? Can the neck side bend? If the measurements are abnormal, and 45 degrees is normal, both sides. So if they move 45 one side but 10 the other, that's abnormal. They need to go to physical therapy. If most likely, however, it's usually like 10 to one side and 15 to the other. That's common at 6 weeks. Kids, however, are amazing. Most amazing thing, I'll put an appliance in a kid. Kid can't move his head. 6 weeks later, the kid's moving normally. No physical therapy is necessary. If the side bending measurements are normal, the TMD assistant automatically fills out a physical therapy referral form before the dentist even arrives in the operatory. So you've already checked the head bending, good. You've written the physical therapy prescription. Of course, the doctor has to sign it. Doctor is the one who does the final diagnosis and treatment. Only the doctor can sign it. You can't sign it. TMD assistant does not sign the referral. The doctor signs the referral. There's a lot of stuff to know too. The dentist then comes in and verifies if the patient needs this referral. He's going to look at the headband, and if so, signs the physical therapy referral, which the awesome TMD assistant already has out because she's already figured out that the side bending sucks. The TMD assistant gives the POHG6 patient a new POHG appointment based on the POHG6 guidelines. So usually we're going to see a patient if they're doing okay, if the measurements are close to normal, 4 weeks. If they're doing really well, measurements are all normal, they're doing great, they're sleeping well, we're going to go 6 weeks, right? If, however, there are problems and you see they're not wearing their appliance, their range of motion, mandibular range of motion measurements are not so good, they're going to come back in 2 weeks. We're going to give them a new exercise 1, and we're going to demonstrate it. You are going to demonstrate it and be absolutely sure that the patient knows where the therapeutic pipe position is so that they can practice at home. The TMD assistant gives the POHG6 patient a no appointment card. We always give cards because people do come in at the wrong time. And recently, you're not going to believe this, someone came in at the right time, but the assistant did not put the appointment in the book. Crazy, but God was good, and there was an hour available for a soft card delivery. Life was good, and she had her card, and it showed that the assistant screwed up, right? The TMD assistant then customizes the POHG6 notes to ensure that everything done at this appointment is documented. So you pull up the POHG6 notes, bang, you do that before the doctor arrives. As soon as the patient's seated, the standard notes are pulled up in the Dentrix charting module. Then you might give them exercise 1. So you put down HO, handout, exercise 1, training your jaw, to go into the therapeutic bite. And you put that in there, you write it in. Then you might put it, and in the notes it says patient new therapeutic bite position. Please change it. Patient did not know therapeutic bite position, right? You are customizing these notes based on the experience. You are the primary provider at this appointment. It's legal, and everything is removable and reversible, and you're supposed to be a pro. Those notes are yours, right? The TMD assistant schedules a follow-up call to check to see if the patient has completed her first physical therapy appointment. So this is really important. A lot of patients don't understand, when you chew with your entire upper quarter, means your shoulders and your neck. Watch people in the mall chew. They chew bouncing their head around. And if their head's stuck, it's going to create problems with their chewing. This is absolutely true. The problem is that a lot of dentists don't believe in physical therapy, primarily because they choose inadequate, poor partners that they get divorced from all the time. They go through 10 or 15 marriages because they're not selective in who they marry. And the same with physical therapists. There just are a lot of physical therapists who don't care. And it's like, I don't know if they're not educated, or they're working in huge clinics that see 4 patients, 5 patients an hour. They're not dedicated to excellence. They're just not. I'm just telling you this. You're going to see it. You don't have to believe me. We'll see patients go 10 visits. We had a young kid up in Berry College that went to a physical therapist in a big package company, and the patient related to us that she went 10 visits, and that physical therapist never laid her hands on my patient at all, not at all. And we sent the patient to get their neck worked, right? So the problem with the professions are the physical therapists don't have anybody evaluating them. They don't feel responsible for getting the results that we want. They're just like they're doing something route over and over, and they're not even looking to see if they're successful at what they do. And sometimes they don't want to do what you send them to do. But we call and we say, hey, how are you doing, Mrs. Jones? We sent you to physical therapy. What do you mean you didn't go to physical therapy? Pull up some notes, put it in. Mrs. Jones did not go to physical therapy as we requested. And a lot of times we do this because patients may not thrive at the end of 6 months because their neck is messed up. And they're doing decent, they're happy, but that neck is going to cause problems later. It is. It's going to cause sleeping problems. It's going to cause jaw problems. And they're going to blame it on us. And then we have a referring dentist or physician that wants to know, did we do a good job? And if the measurements are not as good as we want them to be, and we didn't do as good a job, I get really worried. I want to do well for my patients. Unlike many of these physical therapists, I look to see my results.